If you'd like to go ahead and start by introducing yourself.
Yeah, I'm Dr. Dennis Williams. I'm the medical director here at Kentucky Blood Center.
Awesome. So thank you for being here with us today and talking a little bit more about whole blood, and we'll go over some more topics on how to watch for transfusion reactions, kind of what is low titer O positive whole blood and why are we doing O positive. So kind of the first thing we're going to start with is what are the components in whole blood?
Yeah, so whole blood is basically the initial blood collection when somebody donates whole blood. It's that bag fills with 500 mLs of blood, roughly, and it's got all the components of blood in it, red cells, platelets, and plasma. This is different from components. Component therapy is where you're transfusing each separate component, like a packed red cell, a platelet, and a plasma. We make those components from the whole blood. So each of those components will typically come from one whole blood. When they're separated from the whole blood, they are a little bit watered down in that we add some additive solutions to preserve the cells. They're also stored in different conditions. So compared to a whole blood unit, if you try to transfuse all those components together at once, the equivalent of giving whole blood, one, you're going to have a more dilute product. And then two, you're going to have multiple bags that you're carrying around at different temperatures, as opposed to one whole blood that it's one bag, it's got everything in it already, and it's more concentrated and easier to deal with.
Yeah, great. So how does that differ from storage? So we're storing whole blood, obviously. How is that? Is it easier to store whole blood?
Yeah, much easier. It's just in a refrigerator or at refrigeration temperature. Really the same as a packed red cell. This is different from a platelet that needs to be stored at room temperature, and plasma, which is typically frozen, and then once it's thawed, it's put in the refrigerator. But whole blood is just much easier to handle than having all these products at once with you at the scene.
Perfect for an ambulance.
Yes.
So what about leukoreduction? What is that?
Yeah, leukoreduction is where we remove 99.9% of the white cells from the product. And this is important. It will significantly decrease the risk of febrile non-hemolytic transfusion reactions. Which those are important. They're typically mild reactions. They're one of the more common transfusion reactions, but they can mimic severe reactions, right off the bat, like an acute hemolytic transfusion reaction. So you have to stop the transfusion, evaluate the patient, and if we can minimize those, then we won't run into those problems. It also decreases CMV transmission, and also decreases the chances of a patient making HLA antibodies. So it's very helpful to leukoreduce. The problem with whole blood is that most of these leukoreduction filters will take the platelets out and will also activate them. We use a special platelet sparing filter that will spare the platelets and not activate them. So they're specifically made for whole blood.
That's great. Awesome. So with transfusion reactions, what are some of the things that we need to be keeping an eye on during transport, and then after, once we're walking into the hospital, and keeping an eye before we meet that transfer of care?
Yeah, with transfusion reactions, it's about monitoring the patient from baseline. So any changes, negative changes with vitals, or how the patient's feeling, which can sometimes be difficult in trauma patients who aren't able to respond or aren't verbal. But you would just want to monitor the patient and evaluate any changes in baseline. Some of the big important things we look at are temperature, increase in temperature, fever. Can be indicative of anything from a febrile non-hemolytic transfusion reaction to an acute hemolytic reaction. Changes in blood pressure. A spike in blood pressure, hypertension, could be circulatory overload, or just a febrile reaction, or hypotension could be a contaminated product or an anaphylactic reaction. Also a pulse, and then pain, any new pain that the patient has, especially flank pain, or pain at the site where you're putting blood in, that can be indicative of an acute hemolytic reaction. And then if you do have urine, you can see urine. Any changes in color, like a dark color, can be indicative of hemolysis.
How would we treat some of those? So if we notice that anaphylactic reaction or those acute hemolytic reactions, how can we treat those? Yeah,
so with anaphylactic reactions, you would treat them as any other kind of anaphylactic reaction. If it's just a mild allergic, like a rash or urticaria that you see, you can give antihistamines. Anything more significant like anaphylaxis, just epinephrine, and how you would normally treat one. For temperature, febriles are usually just an increase in temperature, and then some other vital signs. Blood pressure might go up, tachycardia, and you can treat that with Tylenol or any other antipyretic. Anything significant, though, like circulatory overload, that would be one where these units are going in fast, so certain patients can be high risk for even a small volume to develop overload. And with those, you again would treat like you would any patient with overload. At the time, in the scene, usually we would give Lasix, things like that. So yeah, with circulatory overload, it's Lasix if you're using that, keeping the head upright. And you're going to notice with that, and something I didn't mention was, how's the patient breathing? Are they developing dyspnea, hypoxia?
Okay.
Those are all going to be signs of various transfusion reactions.
What kind of patients would you expect to be more likely to have fluid overload?
So that's a good question. There's two risks to think about, or two categories of risks with patients with overload. One is patient-specific. Do they have a history of heart disease, a history of long-standing anemia, because they may have a higher blood volume to start with, underlying kidney function issues, or kidney disease. Those patients are going to be more high risk, and especially high risk for smaller volumes. The other risk is a large volume at really fast. So you're going to be giving fluids pretty quickly, but with whole blood, you're going to have one whole blood, potentially more, in the future. But you're going to be transfusing a limited amount of volume, so the total amount of volume may not be as big of a risk factor in that pre-hospital setting, but definitely the underlying risks to the patient, like especially heart disease, history of congestive heart failure.
Yeah. Okay. Good. So when we talk about O positive blood, we think those aren't the universal donors. So why are we choosing O positive over O negative?
Yeah. So O in general for the ABO would be the universal blood type for a packed red cell. And then O neg would be universal for everybody if we're worried about RH. But what we do worry about most is O. The D antigen, which is the RH, we will especially worry about in young females. With what we say childbearing potential, because we run the risk of, if you have an RH negative individual and they get exposed to RH positive blood, they can develop an anti-D antibody, which could cause problems with future pregnancies, leading to hemolytic disease of the fetus and newborn.
Okay.
The reason we aren't going to carry O negs is that the RH negative supply is extremely limited. Only about 15% of individuals in the population are RH negative.
Wow.
And then O is only about 45%.
Okay.
So you're getting to a really small number. O pos is just much more frequent. We have way more donors and a much larger blood supply for O positive.
Okay. Well, that's great. Yeah. So what if we do know of, we have a patient who has a known history of anti-D antibodies and they are RH negative? What steps should we take to do in regards to that? Should we not give the blood?
So that's a very difficult one. The first one is if you already know the patient has anti-D, that's going to be definitely more of a risk, because now you have an antibody that can cause hemolysis. Now it really depends on if it's showing and what the titer is. Usually what we run into in patients like this, like even in the hospital, is that you're not going to run into an initial issue with hemolysis, as in we don't usually see an acute hemolytic reaction. We see what we call a delayed hemolytic reaction. So the hemolysis will occur 24 hours up to even a week in some cases after the fact. So this is something that's going to usually in this case happen after the fact, after you've stabilized the patient. So the immediate risk still, I believe, the immediate risk of withholding transfusion in a patient who really needs it is going to be much higher than the risk of dealing with this delayed hemolytic reaction after the fact. The other part of that question then is you have a known RH negative person, but they don't have an anti-D yet. So the risk here is them making an anti-D. And again, if it's a young female, potentially then running into issues with a pregnancy later on. The risk of a patient making an anti-D in a typical situation in the hospital or pre-hospital is about 10 to 20%. The risk of that patient being a young female is very small. That's not your common population you're dealing with. And then the risk of a future pregnancy being affected is unbelievably small. It's about 0.3%.
It's pretty low.
So very low. So you're going to risk not saving the lives of many, many young females for that very, very small risk of HDFN in the future.
Right, so that benefit does outweigh that risk.
Yes,
okay.
Significantly.
Great. What is a hemolytic reaction and what causes those?
Yeah, a hemolytic reaction is when the patient has preformed antibodies to red cell antigens that that recognize specific antigens on the red cells that you transfuse. Okay. So those antibodies will bind to those red cells and hemolyze them. Depending on the type of antibody and antigen we're dealing with, you could have acute intravascular hemolysis or a delayed extravascular hemolysis. In the case of RH, that one typically, and almost always, is extravascular hemolysis, meaning that the red cells, they get coated with antibody, and then when they circulate through the reticuloendothelial system, which is predominantly the spleen and a little bit the liver, they get plucked out of circulation. Whereas with intravascular hemolysis, you have an antibody that's capable of forming the membrane attack complex and lysing the red cell within the intravascular space, which is much more severe. It's quicker. It releases all the red cell contents into the circulation, which leads to hypoxia or vasoconstriction and shock. I'm blanking.
That's okay. Got it.
Leads to coagulation issues and DIC and shock in patients.
Okay. So what about low titer? Can you talk a little bit about what that is?
Yeah. So we were talking about ABO compatibility and universal blood products. So I mentioned that O is the universal ABO type for red cells because they have no ABO antigens on them, so anybody can receive them. For plasma, it's the opposite. AB is the universal blood donor. Because with plasma, we're worried about antibodies that we're transfusing. So a donor who is AB has no ABO antibodies. All right. So in a trauma situation where you're giving uncross-matched blood to a patient who you don't know what their ABO type is, you want to give O red cells and AB plasma. Whole blood is a different animal because that's got both red cells and plasma in it. That's coming from one donor. So there is no universal whole blood ABO type. The way we get around that is we choose O, so the red cells are compatible, and then we titer the anti-A and anti-B antibodies in the plasma of that whole blood donation. And we make sure the titers are low enough that they're not going to cause any issues. They're not going to cause hemolysis in a patient. And we have data from many studies that show that titers of pretty much less than 256 are going to be safe and not lead to hemolytic reactions.
Great. Well, actually, let's talk about, so what do you do if, on our daily checks, we see a bag that's leaking or it has damage? What do we do, or it has excessive large clots? What can we do to try to manage that? And when it comes to leaks, obviously bring it in. But what about that damage or the discoloration or clots?
Yeah, any issues that you have like that, you would want to notify the blood center, and then we would change out the unit, because any issues with the product, if it's discoloration or clots, that could indicate bacterial contamination. So we always want to risk on being very conservative on the side of safety. Most of the time it's probably not an issue, but we want to be ultra conservative.
So trying to agitate it wouldn't probably get rid of that discoloration or the clots.
No, and yeah, so definitely don't use it. Let us know real quick, and then we swab them out.
Perfect. So when we do our daily checks and we see tiny clots, is there anything we can do to try to reverse those?
So nothing to reverse them, but not all clots are an issue. So if you have several very small, like the size of grains of sand, then those are fine, as long as if you kind of judge it that in accumulation, they're not any larger than the size of a nickel. A lot of blood centers and hospitals will have parameters in place for the number of clots or granular material that are in the bag, to where they would say you shouldn't use it. So if you have some, then that's okay, and that's what that filter is for.
Great.
I would say in the situation of any patient who, especially in the situation of a young female who is receiving RH positive blood, so in our situation, any young female who gets a whole blood unit, then you should definitely relay that information to the emergency department physician or whoever physician you're transferring care to, that she received an RH positive unit. And then the hospital, the blood bank, they'll ABO type and RH type the patient. If they find out they're RH negative, then they will have a procedure or a policy in place with how to handle that, which has to do with deciding on whether or not the patient should receive RhoGAM or not.
Okay.
And they can receive RhoGAM within 72 hours for it to work. So it's not, you know, it doesn't have to be an emergency at the time, but you need to have good communication when transferring the patient about that they got whole blood, and especially if it's a young female, to be on the radar of that team to evaluate if they are Rh negative, they may need RhoGAM. So they should have a policy with how much, and it depends on how many units they get for their blood volume. If they have a total blood volume less than 20%, that's transfused, then they may be a candidate for RhoGAM. If it's more than 20% of their blood volume, that's usually too much. You'd have to give way too much RhoGAM to be effective. There are some other things in the literature like red cell exchange, but that's actually a category 4, which means there's no proven benefit and it may be harmful. But it's what's most important is the information is given, because the hospital should have a policy in place to deal with that.
Okay. And I'm just curious for my own, what are the risks of RhoGAM?
It's pretty low risk. You know, allergic reactions. There can be some hemolysis, which is another reason if you transfuse over 20% of your blood volume, your RhoGAM is anti-D. So it's going to bind to those red cells that are Rh positive, which is kind of how we don't know exactly how it works, but you know, they kind of mask them away from the immune system. But if a lot of that patient's blood is now Rh positive, it could hemolyze a lot of those. It doesn't usually cause much hemolysis, but it can. But allergic patients can be allergic to it.
Interesting.
And I can't think of anything else.
That's okay. Do you have anything else you'd like to add, or any questions you think we should be asking?
I just think, you know, one is it's really important to transfuse these patients when they definitively need it. The benefit of transfusion far outweighs any risk. We've done things to mitigate the risk by using low titers. And then also another key is the information, the handoff of the patient to the hospital. You know, giving the information to that hospital that patient was transfused, so that they can be looking at, and if there was a transfusion reaction, if there are any issues, then that information would need to get to the hospital where you're transferring care. The other thing that's important for them to know that the patient got transfused is so they can monitor the patient for transfusion reactions after the fact, because a lot of these transfusion reactions can occur after the transfusion, especially when you're transfusing so quickly, within 3 or 4 minutes. You can see some of these even acute reactions occurring hours after the transfusion. So, good to know. Yeah, information, communication. Good communication. That's the word I was looking for. Communication is key.
Yeah. Good. So if I had a patient in the back of my ambulance who was hemorrhaging and I think that they needed some whole blood, what could that conversation look like if they do have concerns about the risks? How can I relay that to them in a non-medical way and make them feel better about this?
Yeah, so with consenting a patient for transfusion, discussing the risks, I usually divide it into transfusion reactions versus infection, which infection really is a type of transfusion reaction, but I'll usually separate the two. The biggest risk that most patients worry about is what's the risk of acquiring an infection from the blood, you know, from the donor who gave the blood. So the risk is very minimal. HIV, hepatitis B, hepatitis C are the 3 biggest ones. We do molecular testing on every donor every time they donate, so the risk is extremely small. It's about 1 in 2 million for HIV, 1 in a million, or 1 in 2 million also for hepatitis C, and then 1 in 800,000 to a million for hepatitis B. So very, very low risk. Transfusion reactions can occur. Most of them are pretty mild and easy to take care of. The more significant ones are pretty rare. And really those risks are very small compared to the benefit that the patient will experience.
So just assuring them that, you know, their risks are low for both of those, for reactions and infections, and just reiterating the benefits of this outweigh any kind of small risk. Yeah, and totally understand it. You got to do it really quickly because they need blood emergently.
Can't
have a long conversation about it.
Yeah.